Good morning, everybody. I'm very happy to be invited here in this great meeting in great location. Thank you so much for the committee. And I'm actually probably presenting pretty much the same that you were hearing already from the previous speaker. Maybe a little dense also. It's a huge topic that you can't really not present in a short time of this, but I'm gonna try. This is how I advance my slide. So this is where I work in Houston. It's the Texas Medical Center, all these buildings, several medical schools, several hospitals, and this is the Children's Hospital Memorial Hermann. I will discuss the pre-anesthesia evaluation from the anesthesia standpoint and discuss some anesthesia management for these children and the classification and outcomes also. And I have to speak fast. I try to go through all my slides in 40 minutes. It's difficult, but I will try. So this you heard already this morning. There will be more and more patients coming to the general hospitals because now the survival rate of the surgery and the treatment for congenital heart disease has improved so much over time. Here you see just a slide that shows you the distribution of the ages of patients who have cardiac surgery. And the survival rate, if you heard earlier, is over 90%, and the distribution of the lesions are about 55 for simple, 30 for moderate, and then 50 for complex lesions. And these patients will show up in your OR. Here are the most common lesions, VSD, coarctation, and this was mentioned before also. The classification, there are actually several classifications of congenital heart disease, and they overlap somehow. There's the shunt, the mixing lesions, the obstructive lesions, regurgitant lesions that are mostly more present in patients who have been corrected actually, and the single ventricle lesions. Just here another classifications with the different types of lesions that go under these classifications, and they overlap, and as was said before, they are so complex, and each lesion actually has so many possible variations and also surgical approach in some regard that there's no way that you can just have, okay, for this you always do this way. It's really an individual approach to each child. And here comes the preoperative evaluation. You really cannot do this in 5 minutes. It's not like, you know, normal child comes, you see, hello, good morning, how are you? This is not. You have to sit down, you have to identify the lesion, you have to understand the lesion and see what previous corrections was there. See the imaging, and if you don't, as was said earlier already, take advice from somebody who knows it. Talk with the pediatric cardiologist who is following this child. Of course, it's all different if it is an emergency situation, but still, you know, sometimes a little half an hour to look into the details goes a long way. When you do physical examination, really focus on the cardiac signs and symptoms. Failure to thrive is very common in these children who have heart failure, how many cyanotic spells, arrhythmia, feeding problems, all these are delay in milestones, all these are signs that show you how sick your child is. And very often these lesions are also associated with malformation, as was mentioned earlier, Down syndrome or DiGeorge syndrome. They can have additional facial malformations, so the airway can be a problem. They also, because they have been maybe intubated for some time, they can have tracheal stenosis, so you want to look into this. Some lesions are also more prone to have respiratory infections combined, and again, the cardiac situation should be optimized, and you really you need the help of the the pediatric cardiologist. So here's just an idea, when would you need a cardiac consultation? And in cyanotic patients, it should be really done within the last 6 months, even if they're well compensated, and of course, if not, they should be immediately preoperatively done. And for the cyanotic patients, same, well compensated or less compensated, the consultation should be pre-op immediately for the poorly compensated. You need to look at the hematocrit. Cyanotic patients specifically can have a very high hematocrit, and if you follow actually the increase over the hematocrit over time, it gives you an idea also, if you have access to these data, it gives you an idea if the hypoxemia is worsening or not. Coagulation was discussed earlier. Electrolytes, if they're on diuretics, you want to optimize all this before you go into anesthesia. Same thing here, we continue all medications pre-op. Just when the patient is of certain antiplatelet therapy and Coumadin, then there is a discussion. Can we stop it? What is the procedure? That's a discussion between the surgeon, the pediatric cardiologist, and the anesthesiologist. I think teamwork is here really key for have the best access. And if you are in a hospital that normally don't do this, just go on the phone and talk and make that communication happen. NPO time is crucial. You do not want dehydrated children. For some lesion, it's really very important. For BT shunts or fallow TOF patient, they really do not like to be dehydrated. So they should really be allowed to drink clears until 2 hours prior and then take their medication. And if possible, be the first case in the morning when everybody is alert and not tired. And also they should be awakened in the morning to drink and not say, oh, my child was asleep, it isn't. But actually parents who have children with these diseases, they're generally pretty well informed, and they understand that these things are important for their children. For the monitoring, normally standard ASA monitoring. Precordial stethoscope is used very rarely, I would say. We not always use a 5-lead EKG, but temperature probe is important. Non-invasive blood pressure, and then you have to think if there is any stenosis somewhere, where do you put your blood pressure to make sure if you have a coarctation, for example, the best blood pressure is on the right arm because that shows you the pressure, the central pressure. Same for saturation probes. You have to think where you put your saturation probes. It's in general good to have 2 different saturation probes. So if you have just a technical problem with one, and you have only one, it's not immediately a stressful situation. Is this now my child, or is this a technical problem? So it's advised to do this. Capnometry should be also used, let's say you just do a sedation for a colonoscopy or something, deep sedation. You still should use capnometry for these children, even if they're not intubated. IV access also was mentioned before, can be very difficult because they had multiple IVs and central lines. And so in general, if you know you will get an IV, you can do an inhalational induction and get an IV afterwards. But if not, you may want to consider that you place an IV before under just a little bit of sedation for this child, or you have a PICC line placed or something, if you have time to do this. Arterial line also depends on how stable the child is and how invasive the procedure is. Also here you have to think about the location. You have to avoid A-lines on the side of the shunts, and brachial arteries are generally avoided in children too. Central line also are most of the time in a peripheral hospital critical. If you don't do this on a regular basis, you may want, if you really want a central line, ask the surgeons to do it. TE, you probably won't have this availability in a peripheral hospital, but it's sometimes more useful to look into fillings. And urinary catheter if you have a long procedure and you need to follow up urine output. So the goal actually is optimizing your oxygen delivery, optimizing your ventricle function, maintain euvolemia, and this is very, very important. avoid increase of oxygen demand and tachycardia and contractility by having a good sedation for your child and deep anesthesia. Of course, it's a question of, very balanced question. Maintain cyanosis is by all means possible. Premedication, mentioned again before, too, is really important, and you do not want to have a crying child that becomes more cyanotic during induction. So midazolam is normally used. We use midazolam PO 0.5 milligrams per kilo and IV 0.1 to 0.2 milligrams per kilo, and I think that's the usual doses that are here. Children under 6 months normally do not receive premedication in our hospital, and sometimes Down children, they are so sweet and they sometimes don't need this either. So, oops, I need to go back one slide. When you induced anesthesia, you have to remind that if you have a right to left shunt, so your blood is actually not, your blood will be mixed and not going entirely through the lung, you will have a slower induction, and you really want to avoid, you have to be patient, this was mentioned before too, you have to be patient and not keep the sevoflurane for too long on high concentrations. IV induction can be faster in right to left shunts because the blood is actually immediately going to the arterial side. So, and in all others, it doesn't really impact. Propofol, we use propofol depending on an unstable child, but you have to keep in mind it makes vasodilatation, and you have to use small doses and incremental doses. And I think somebody who does pediatric anesthesia anyway, we do premature babies, we are used to use small incremental doses and not like on the adult side you empty the syringe, you don't do that in pediatric anesthesia. Ketamine is our drug to go for. Combined with fentanyl very often. Etomidate also has no effect on myocardial contractility and is stable. Dexmedetomidine is more and more used specifically for sedation or in addition to fentanyl. At the beginning there was a big skepticism because it produces some bradycardia, but if you induce slowly, and actually we also use it quite a bit in the ICU for ventilated patients. Opioids, I already said, fentanyl is the most commonly used opioids, and remifentanil for short procedures. If you do a bronchoscopy, for example, or an EGD, you don't want to use too much fentanyl, and remifentanil really has a 3 to 5 minute window. Muscle relaxation as needed, and regional anesthesia can be extremely beneficial for postoperative pain management. Again, in the goal to decrease stress and to decrease complications from stressful situation. Airway management, whatever is needed for the procedure you're doing, everything is possible. Spontaneous ventilation with nasal cannula and capnometry, mask or LMA, or of course endotracheal tube. I just can only reinforce this. It's really important to have no air bubbles in your IV. Don't let anybody else set your IV up. Check it yourself. You, even in a left to right shunt, you can have a reversal of shunt or in mixed shunts, and you really don't want the devastating situation to have a stroke-like symptom in a child. Avoid hypothermia. Hypothermia also is increases morbidity and mortality. I'm not going to the endocarditis. This was already addressed before. Endocarditis prophylaxis has been significantly decreased. There are only a few indications, and it was addressed this morning in the previous lecture. So for the emergency and postoperative care, again, regional anesthesia can be very beneficial. Of course, you have to think, is the child, aspirin normally should not be a contraindication. It says my battery is running low here. Okay. Sorry, on my screen it says battery is running low. Neuromuscular blockade needs to be reversed, and in the pack you really need to make sure that you monitor oxygenation and ventilation. Also, it's important for these children to make sure that they take PO fluids as soon as possible so they can take their regular medication again. And for that, you also need PONV prophylaxis. And that should not be different from a normal child or a child with cardiac disease. I can't advance it here. So do we do this, do we do it in outside patient or in-house patient? Again, it depends, thank you. This depends on the situation. If the cardiac situation is, disease is stable, it was an uneventful anesthesia, the family needs to be on board, they shouldn't live too far away from the hospital in case they need to come back, surgery should be minor, and the child should be able to resume oral fluids and take the regular medication. And always keep in mind, children with, at every stage, there are very few that are totally repaired. No, there are some that are totally repaired normal, but many of these children have limited reserve. And so the decision is. So basically, now trying to a little bit talk about the lesions that are there, and there are actually two big types also. And again, I said there are multiple classifications and they overlap, many of them overlap. So there's the biventricular repair, that's generally going without palliation. There are exceptions to that. And then there's the univentricular repair that normally has a 3-stage palliation. And these are, as mentioned before, are children that should really be done in a center where these kids are, where people are trained to take care of these kids. And I can only enforce every of these lesions has a large spectrum of severity and a large spectrum of variety of surgical repair. For the biventricular repair, these are just some lesions that you can see there. Usually, some of them, depending on the severity, need palliation with a pulmonary band, for example, or but most of them are a single repair. So now dividing these are just these show you what are the hemodynamic consequences of right to left shunt, left to right shunt, and your hemodynamic goals. And for somebody who's not doing this on an everyday, I feel there should be some place around, or a conversation or a book that you can read it before you do these kind of procedures. You have to have something in hand to understand. If somebody does not think about pulmonary resistance, systemic resistance, and how this is balanced on a daily basis, it is not in your head, and you will need to have something to help you to support this. So one example for the left to right shunt is the VSD, and you see here there are different types, and different types have different surgical repairs and different consequences, and some of the larger VSD can really hypertension. This also was addressed. Pulmonary hypertension is one of the major problems in outcomes. I will come back to this. And here what is really important is the relationship between pulmonary and systemic resistance, and there is a fine balance on how do you influence one and the other. And you have to imagine, if your pulmonary flow is very high, your systemic flow will be lower, and your heart needs to pump way more to deliver the same oxygen demand to the peripheral system. The unrepaired defect, and we have seen this in the previous lecture too, you see you really want to avoid fluid overload, you want to avoid increase of FiO2, decrease of CO2 because this decreases the pulmonary vascular resistance, and then it overflows again into the pulmonary. For the repaired defect, there can be arrhythmias. Many children who had cardiac surgery have problems with arrhythmias, and that is to be considered when you anesthetize them even after repair. So the AV canal is actually pretty common in Down syndrome, associated with Down syndrome frequently. And here you have a free communication before in the four chambers, and that actually, in general, they can be very well balanced, and we have done children, they just go to anesthesia very smoothly, and again, the severity being so extreme that it's difficult to say this is the rule to follow. But once they are repaired, they actually can have residual defects because they had a common valve, and now they have two separate. Okay, good. Okay, so I'm a little off my lecture here. Coarctation of the aorta is one of the obstruction, and these children are actually dependent on their continuous PDA, and they may come to you, probably, I don't know, in a hospital, but if you have a baby like this, they're dependent on the PDA, and they normally should come on a prostaglandin infusion to keep the PDA open. That's the only way that blood goes to this system. And so you see, when you look at these lesions, they are so particular that when asked to give just one advice, it's nearly impossible. So it's now coming to the mixed lesion, the cyanotic lesions, as you call them. The first procedure, most of the time that's performed for these procedures, is a BT shunt. So you may encounter children that are partially repaired, that have a BT shunt. The BT shunt actually brings blood from the subclavian artery, normally to the pulmonary artery. And this is a very sensitive shunt. These children are dependent on very good flow, on very good volume. If you dry, if your child is hypervolemic, the shunt can clot, and that's basically a disaster. It can really be death on the table. You want to keep the circulation the saturation between 75 and 85. Everything over 85 means your pulmonary vascular resistance is going to decrease, and you will have an overflow of pulmonary overcirculation with the risk of congestive heart failure. And if you lose suddenly your SRO2 during the procedure, that means that most likely your shunt is occluded. And the cath lab is the next step. It's very difficult to get these children back once they go this road. TOF is another mixed lesion where it is really important to have a balance between pulmonary and systemic resistance. And when you see children, sometimes you have older children that have not been repaired. They actually, in order to control the systemic resistance, they go in the squatter position. They increase the systemic resistance like this, and so more blood is allowed to go into the pulmonary system. Same here. Today these TOF kids get repaired very early, so you should probably not see them in a common hospital. When they are repaired, they are prone to arrhythmias, and often have an ICD or a pacer implanted. Some of them get a first step repair, and some have actually a BT shunt before final repair. These kids can go into what everybody knows about Tet spells, and that's actually a vicious cycle, and it's important to break it, and these children need then 100% oxygen. They need a bolus of volume. If this happens during anesthesia, you need to deepen the anesthesia. You need to phenylephrine is the medication of choice to increase systemic vascular resistance, and beta blocker is sometimes used for the infundibular spasm. And ECMO would be the last resort in these children if you cannot break the Tet spell. The hypoplastic left heart, this is a really complicated lesion, and had basically, these children died years ago before the Norwood procedure was actually, I think it was in the late 50s, you may correct me there, and from then on the survival improved. These are children that should not be done in a peripheral hospital. They go through several stages of palliation, and as you mentioned before already, they depend on passive flow from the venous return, so they're very much preload dependent. The data that I will show in a second will show you that they should really not be done in a normal hospital. The repaired heart, though, you have to remember, may have no normal cardiac function, may have residual shunts, poor myocardial function, may be prone to arrhythmia, and present with pulmonary hypertension, severe and regurgitant lesions. And here again you see the hemodynamic consequences, whether it's on the right side or the left side, and the goals you should basically look for when you do anesthesia. Long consequences, and the scary part are the four topics that were discussed earlier, and I just briefly mention them again: pulmonary hypertension, congestive heart failure, cyanosis, and arrhythmias. Pulmonary hypertension to the left to right shunt increases the blood flow in the lungs and ultimately increases the pulmonary resistance, and it can give you vicious circle, and you have a cardiac arrest at the end. And so the treatment of a pulmonary crisis is, of course, 100% oxygen, hyperventilate to induce respiratory alkalosis. Nitric oxide would be the first choice of the treatment, and support the cardiac output, and again, at the end, CPR and possibly ECMO, which you probably would not have in a peripheral hospital, and that's one reason why these children should not be treated in a general hospital. So here you can see this is a study that looked at pulmonary hypertension for non-cardiac surgery, and they found, you can see children with pulmonary hypertension, they have a much higher risk of not only suffering cardiac arrest but also dying under anesthesia. Congestive heart failure was already discussed in the previous lecture. Anesthesia management for heart failure is actually not very different from the adult management, and I'm not going to insist there. Cyanosis due to right to left shunt or to inadequate pulmonary blood flow or the mixture of oxygen and deoxygenated blood into the systemic circulation. And as was mentioned, it causes a lot of other organ damages. And if your hematocrit is over 65, your oxygen delivery will be compromised. And so that is a discussion that needs to happen also with the pediatric cardiologist, whether phlebotomy should be done or not. The hyperviscosity signs for hyperviscosity actually are headache, dizziness, fatigue, and these are signs to look out for in these children. And of course, important here, avoid dehydration. Thrombocytopenia is often present, and they're used to hyperventilate in order to deliver more oxygen to their system. And so when you ventilate them, you need higher tidal volumes to ventilate them correctly. Also, your end-tidal CO2 will not be correct for these children, so you really have to have a low threshold to do a blood gas and check this. Same for your saturation. In cyanotic children, the SiO2 under 80 is not very reliable, so you need to check this with blood gas. IV access is often difficult, and again, I only can repeat, fluids are really important. These children should not be dehydrated. Arrhythmia, what's important here is actually when these children come with devices, with implanted devices, they need to be interrogated normally the day of. We have a policy that any pacer or ICD device needs to be interrogated within 24 hours prior to anesthesia. And there is a practice advisory that was published in Anesthesiologist in 2011 that gives kind of a guidance on how to proceed. Some children are on amiodarone, and that should not, as all the other medication, should not be discontinued. So again, just a little summary for intraoperative considerations: pulse oximeter, A-line, and also electric activities. On the EKG, do not guarantee perfusion. They may be there, so you always have to check. You always also want to touch the child, look at your capillary refill, look at things that we have actually lost to look at over time because we have so many monitors. But I think they are important. For your pacers, always have a backup in case your pacer has a problem. And think about what are my hemodynamic goals and ventilatory goals for the specific child with that specific lesion that I have there. And there is, again, the discussion. So I wanted to bring up just two recent publications that have tried to stratify the risk for non-cardiac surgery. One is they have looked over 6 weeks at all the children that they anesthetized, 2,200 children. 100 of them had congenital heart disease. And they looked at how can we they stratify? They put, according to the cardiac lesion, they decided on low risk, moderate risk, and high risk, similar what was shown below. And then once the cardiac lesion was actually defined as low risk, moderate, and high, then came the other additional components that. So a patient less than 1 year, we know they are more complicated even when they're healthy, have more problems, additional comorbidity, and so if all these is present from a low risk, you go to moderate risk. Same on the next, from moderate risk, you can go to high risk. So they actually divided, they found out that 23 children were classified at low risk, 66 moderate, and 11 as high risk. And these high risk kids, they decided these will be done only by pediatric cardiac anesthesiologists. And I think it's important to start thinking about this as we have more and more patients coming with corrected hearts to us, to think about it, how do I organize my team? I cannot force somebody who has, I cannot force all the CHD patients on the cardiac pediatric anesthesiologist. There are not enough of them.
2 minutes.
So,
remaining 2 minutes, Professor.
2 minutes? Okay, so I'm just going to talk about the second study that was published, and that's a retrospect analysis of the National Data Bank for the from the American College of Surgeons, the NESQ, where all data are entered from children's hospital, children under 18 years who come for non-cardiac surgery and have congenital heart disease. And they this data bank look at tremendous variables, 129 different variables. So what they did, they took out of this group major CHD and severe CHD patient. And you see there how they classified major is repaired with residual hemodynamic abnormalities. For example, a TOF with wide open pulmonary insufficiency or hypoplastic heart syndrome, including stage 1 repair, and severe is uncorrected pulmonary hypertension, ventricular dysfunction requiring medications, or children listed for heart transplant. So they took 4,375 kids with major and severe CHD in order to find what are the points, what are the relevant points that can tell us ahead of time these kids are a special group. And then they used close to 3,000 children to validate this score, this cohort and this score. So here are the different variables they looked at the beginning: age group, ASA, type of procedure, prematurity, type of procedure, was it emergent or elective, surgical specialties, craniosynostosis or whatever surgery there is, all the surgical fields, preoperative respiratory disease, preoperative oxygen supplementation, were they trached, kidney disease, was there CPR preoperatively or any other surgery 30 days before, was there preoperative transfusion, and a preoperative event was defined as an event occurring between the day of hospital admission and the day of surgical surgery. So they looked at all these, and they found, out of all these, they actually found, first of all, that the incidence of mortality in the derivation cohort was 4.7%, and in the validation cohort was 4%. So very close both. And they found 8 preoperative predictors for in-hospital mortality, and they used these 8 predictors to do their logistic regression model. And these 8 are emergency procedures, severe CHD, single ventricle physiology, surgery within 30 days prior to the procedure, inotropic support, preoperative CPR, acute chronic kidney injury, and mechanical ventilation. And the interesting thing here is that they did not find that the surgery itself had any influence on mortality, that if these sick children had major surgery or if they had just a basic dental procedure, the risk was the same, did not influence them. And I think this is a very important information, because very often we say, oh, this is just a short little procedure, why don't you do it? And this shows us that we shouldn't. So the risk stratification were then from 0 to 10, they created a score. 3 is low risk, 4 to 6 is medium risk, and over 7 is high risk. And you can see that here you have the risk stratification down there, the scores, how many risk factors you have, and you see the mortality is the red line, increases to 50% mortality if you have a score of 10. And the single ventricle children appear to be at an increase of in-hospital mortality regardless of their functional status. If they're stable or unstable, they have a very high risk of cardiac arrest for non-cardiac surgery, and a very high risk of in-hospital mortality. So my conclusion, just most children with moderate can tolerate well-managed anesthetic. And as I said before, if it's in a hospital where you used to do children, you probably may be a little more comfortable. If you don't use, then I think I would always tend towards, I'm not going to do this because I'm not comfortable and it's not safe for the child to do it. So I would be very careful and have a plan for postoperative care too. If you can't provide adequate postoperative care for these children, then it's another reason to maybe transfer them to a center where they can. Thank you very much.